Welcome to this medicine masterclass on the second cranial nerve, the optic nerve. The optic nerve is a sensory cranial nerve which carries impulses from the retina towards the visual centers in the brain. When examining this nerve, there are several items that you should focus on. Start by inspecting the pupils, assessing their size, their shape, their color, and ensuring that they are equal. Examine the pupillary reflexes by shining light into the right and left eye. Assess the direct and consensual response, and also swing the light from the left to the right sequentially to perform the swinging light test. Examine the patient's accommodation, that is, the ability of the pupils to converge and constrict when changing gaze from a distant object to a proximal or near object. Examine the patient's visual fields, including the blind spot. Examine the visual acuity and color vision using a Snellen chart and Ishihara color plates, and then offer to and perform fundoscopy. It's important to appreciate optic nerve neuroanatomy to help correlate clinical signs. The optic nerve, which consists of fibers from the temporal retina and the nasal retina, converge and leave the orbit via the optic canal towards the optic chiasm. At the optic chiasm, the nasal fibers, which correspond to the temporal visual field, decussate, whereas the temporal fibers, which correspond to the nasal visual fields, continue to travel ipsilaterally. And therefore, the optic tract contains fibers from the ipsilateral temporal hemiretina and the contralateral nasal hemiretina. These fibers then travel towards the lateral geniculate nucleus, and from here, further fibers relay information towards the visual cortex. These fibers are known as the optic radiation, and there are two key loops to be aware of, an inferior loop and a superior loop. The inferior fibers course around the temporal horn of the lateral ventricles and then turn medially and posteriorly towards the visual cortex, and this inferior loop is known as Meyer's loop. The superior fibers, known as Baum's loop, course through the parietal lobe and then head towards the visual cortex. The region that receives all of this information from the lateral geniculate nucleus through these loops is known as the primary visual cortex. Now we're going to move on to the examination. We start by inspection. Inspect the pupils carefully, looking at their size, symmetry, and their color. Normally, the eyes should appear symmetrical and central. The pupils should be the same size, approximately 4 millimeters, and the irises of each eye should appear to be the same color. The pupils may appear constricted, and this is known as miosis, so they may be 1, 2, 3 millimeters. And this may be due to a normal parasympathetic response to bright light, or it could be as a result of drugs such as opioids or sedatives, or any drugs that potentiate the parasympathetic response, such as cholinergic drugs such as pilocarpine. Or the eyes or pupils may appear dilated, and this is known as mydriasis. So the pupils may be 6, 7, 8, or 9 millimeters. And this may be as a result of a sympathetic response to dim light, or drugs such as cocaine, amphetamines, or ketamine, or any drugs which would potentiate the sympathetic response, including anticholinergics such as atropine. The eyes may appear a different color. So you can see here, normally the iris of each eye should be the same color. However, as you can see in this cat, if there are different colors, this is known as heterochromia iridis. This may be more subtle, so you can see here in the top image of the eye where there's two tones and two colors within the iris, and this is known as peripheral heterochromia. In the inferior picture, if there is a different color around in a central distribution, this is known as central heterochromia. Other abnormalities may include asymmetrical appearing eyes. If the patient had a Wright-Horner syndrome, the characteristic features of this would be miosis, that's a constricted pupil, ptosis, a droopy eyelid, enophthalmos, which is a sunken eye, as well as ipsilateral anhidrosis, which means that the affected side there is a loss of sweating. And this is caused by damage to the sympathetic trunk, and that can be caused by Pancoast tumors, which are apical lung tumors, or an injury at the brachial plexus. Other obvious eye signs that you may see on inspection is a cranial nerve 3 palsy. So in a right cranial nerve palsy, you would expect that the right pupil is dilated. And that's because the oculomotor nerve, which is a parasympathetic nerve, if that's damaged, you will lose the constrictor mechanism, and so the pupil will appear dilated. The patient would also have ptosis, a droopy eyelid, and that's because the oculomotor nerve innervates the levator palpebrae superioris muscle, which is responsible for keeping the eyelid in its appropriate position. Moreover, the pupil is described as being in a down and out position. Out because the loss of the medial rectus, which is with unopposed lateral rectus innervation from the 6th cranial nerve, results in the pupil being abducted. Down because the unopposed action of the superior oblique muscle from cranial nerve 4, the trochlear nerve, results in the pupil being in this position. Having inspected the eyes, move on to examine the pupillary reflexes and the swinging light test by using a torch to shine light in the eyes. It's important to appreciate the relevant neuroanatomy that helps facilitate the pupillary reflexes. And to do this, it's important to understand the relationship between the 2nd cranial nerve, the optic nerve, and the 3rd cranial nerve, the oculomotor nerve. Recall that the optic tract fibers, as well as their neuroanatomy that we discussed previously, also send fibers to the ipsilateral pretectal nucleus. This is a nucleus that's found at the midbrain at the level of the superior colliculus. This nucleus is an important nucleus and projects to the ipsilateral and contralateral Edinger-Westphal nuclei, which are also in the midbrain. The Edinger-Westphal nuclei have oculomotor nerve fibers, which synapse with the parasympathetic neurons in the ciliary ganglion, and it's the ciliary ganglion that innervates the ciliary sphincter, causing pupillary constriction. And that's why, if you shine a light into one eye, you would expect that eye to constrict, but due to the bilateral innervation of the Edinger-Westphal nuclei and the bilateral activation of the oculomotor nerves, the contralateral eye should also constrict. And these two phrases are used. The direct pupillary reflex means that the pupil in which light is being entered should constrict, and the consensual reflex is the indirect response, that is the eye which light is not being shone into would also constrict. And a swinging light test is where the torch is moved between one eye and the other to detect whether or not there's a relevant afferent pupillary defect, and we'll talk about this in a moment. So let's take two scenarios. Let's consider the left optic nerve being damaged. The left optic nerve is part of the afferent limb of this circuit. So if we look here, let's introduce damage there to the left cranial nerve 2, to the left optic nerve. What would happen is if we shine light into the left eye, that would not be transmitted through that damaged nerve to the pretectal nucleus. Therefore, the ipsilateral and contralateral Edinger-Westphal nuclei are not innervated. There is no activation of cranial nerve 3 on either side, and so you lose the direct left response and the right consensual response. However, if in the same patient you shone light in the right eye, the right cranial nerve 2 is intact, which would activate the ipsilateral and contralateral pretectal nucleus, and so you would have a direct right response and a left consensual response intact. Now consider if the left oculomotor nerve was damaged. Recall that the oculomotor nerve is involved in the efferent limb. So in this situation, if light is shone into the left retina, the optic nerve is working to transmit information to the pretectal nucleus. The pretectal nucleus activates the Edinger-Westphal nucleus ipsilaterally and contralaterally. When it activates the ipsilateral left Edinger-Westphal nucleus, we know that there is left oculomotor nerve damage, and so the left direct response is lost. However, the contralateral Edinger-Westphal nucleus and the right oculomotor nerve are working, and so the right consensual reflex will be present. Now let's shine light into the right eye of this same patient. You would expect that because the right optic and oculomotor nerve are working, you would have a direct response. However, when the right pretectal nucleus activates the left Edinger-Westphal nucleus, the damaged left oculomotor nerve will result in an absent left consensual reflex. So putting this information together, it's easy to understand a relevant afferent pupillary defect. So this is determined by the swinging light test. The pen torch is moved between the two pupils, and the pupils are observed for their ability to constrict as light enters each eye. Now, a relevant afferent pupillary defect or a Marcus gun pupil is as follows. Normally, when light is shone into either eye, you'd expect a good constrictive response. However, when the afferent limb in one of the optic nerves is damaged, partially or completely, both pupils will constrict less when light is shone into that affected eye compared to the healthy eye. The pupils therefore appear to relatively dilate when the swinging torch moves from the healthy eye to the affected eye. And this is termed a relative afferent pupillary defect. And the damage to the affected optic nerve can be due to optic neuritis, ischemic optic disease or retinal disease from trauma, radiation, tumor, or even a retinal infection from cytomegalovirus or herpes. So the neuroanatomy helps understand how these tests correlate to the clinical findings.
Once the pupils have been inspected, and the light test has been performed for both direct and consensual responses, as well as a swinging light test, move on to examine for accommodation. The accommodation reflex occurs when a patient is asked to focus on a distant object in the room and then to focus on an object that's very close to their eyes, approximately 20 centimeters from their face. A normal response is for the pupils to converge and to constrict. Once this is done, assess the patient's visual fields. Sit opposite the patient at a distance of about 1 meter. Ask the patient to cover one eye with their hand, ideally with the tips of their fingers. If the patient covers their right eye, you would cover your left eye to mirror the patient. Ask the patient to focus on a part of your nose and not to move their head or eyes during the assessment. Position a hat pin at an equal distance between you and the patient and assess the patient's peripheral visual field compared to your peripheral field, and then slowly move centrally and ask them where they're able to see the hat pin. Compare your visual fields and determine whether you're able to see in all of the visual fields. There are a number of optic nerve lesions that will result in various visual field defects. If at point A, where there's a complete transection of the optic nerve, the patient will present with ipsilateral complete visual loss in the affected eye. If, however, the defect is at point B, the optic chiasm, where you have the decussation of the nasal fibers, which correspond to the temporal visual fields, then the patient will present with a bitemporal hemianopia. And bitemporal field defects are a hallmark of an optic chiasm lesion. The most common presentation of a chiasmal lesion is with superior defects, and that's usually due to compression from below the optic chiasm, usually from a pituitary adenoma. Pressure from above the optic chiasm leads to inferior defects, suggestive of a craniopharyngioma or a third ventricle tumor. Beyond the optic chiasm, shown as point C, at the optic tract, if a patient has a lesion here, you would expect a contralateral homonymous hemianopia. Beyond this, at the optic radiation or point D, a patient develops contralateral superior quadrantenopia. Now bear in mind that with parietal lobe lesions, you would expect an inferior contralateral quadrantenopia, and with temporal lobe lesions, you would expect a superior contralateral quadrantenopia. And finally, towards E, the optic striate cortex itself, or the visual cortex, patients would develop a contralateral homonymous hemianopia with macular sparing. And if there's complete cortical infarcts, the patient would develop cortical blindness. So this slide demonstrates the various visual defects. At the optic nerve, a complete loss; at the optic chiasm, a bitemporal hemianopia; at the optic tract, a contralateral homonymous hemianopia; at the optic radiation, a contralateral homonymous quadrantanopia, either inferior with parietal lobe lesions or superior with temporal lobe lesions. And in the visual cortex and the striate cortex, you would expect a contralateral homonymous hemianopia with macular sparing. As well as these specific visual field defects, also assess for visual neglect or sensory inattention. In this condition, a patient develops a deficit in the awareness of an entire side of their visual fields. And this is not due to an optic nerve pathology, but usually due to parietal lobe injury following a stroke. And this results in an inability to perceive or process stimuli on one side of the body. The side of the visual field that's affected is contralateral to the location of the parietal lesion. And if you ask the patient to draw a clock, they'll only draw on one half of that, indicating that they have neglect. So following the visual fields, the next thing to do is to determine whether you can elicit the patient's blind spot. Sitting directly opposite the patient, asking the patient to cover one of their eyes with their hands, ask the patient to focus on a part of your nose. And with a red hat pin, which should be equidistant, determine their blind spot, ensure it matches yours, and then move the hat pin in a square motion and determine the size of their blind spot. If it's enlarged, it will mean that you're able to see the hat pin before they are able to see theirs. And of course, this is dependent on your own visual fields and blind spot being normal. The next thing is to test the acuity. Visual acuity is tested using a Snellen chart. The patient is asked to stand 6 meters away from the Snellen chart to cover one eye at a time and continue reading the entire Snellen chart to the lowest line that they're able to read to. If the patient has poor vision, a pinhole can be used, and if vision improves with the pinhole, that suggests that there's a refractive component to the patient's poor vision. Along the sides of the Snellen chart, there are some numbers like 6'6". 6'6" indicates that a person with normal vision should be able to read that line from 6 meters, and that's therefore normal vision. But an acuity of 6'10" means that a line that a person should be able to read at 10 meters, this patient can only read from 6 meters. Now move on to examine the patient's colour vision. Using Ishihara colour plates, these are plates which contain coloured circles, and within those embedded is a number, and the patient is asked to read and discern what the number is. If they have difficulty doing this, they may have red-green colour blindness. This may be as a result of optic neuritis, vitamin A deficiency, or demyelinating disease. Finally, move on to perform fundoscopic examination. You should comment on the retina, the vessels, the optic nerve, and the macula. An important finding you should be aware of is papilledema. The signs of papilledema on an ophthalmoscope include, as demonstrated here, venous engorgement, blurring of the optic margins, an elevation of the optic disc, and Patton's lines. These are radial retinal lines that cascade out from the optic disc. So as a checklist to examine the second cranial nerve, ensure you've inspected the pupils, assess the direct and consensual pupillary reflexes, perform the swinging light test, assess their accommodation, assess the visual acuity, their colour vision, their visual fields, assess for neglect on either side, assess the blind spot, and offered or performed fundoscopy. Now we mentioned that the optic nerve is examined along with cranial nerves 3, 4 and 6, the oculomotor, the trochlear and the abducens nerve. Thank you for attending this medicine masterclass.